In almost every field of medicine, if you get a submucosal injection and then immediately swell up, the assumption is that, well, something went terribly wrong.
Right. It's an adverse event.
Exactly. But if you step into a gastroenterology suite and you watch a surgeon getting ready to resect a tumor from the bowel, that exact same tissue swelling isn't a complication. It's actually the literal goal of the procedure.
Yeah, it's the only thing standing between the patient and a really life-threatening perforation.
It's wild. So, welcome to this deep dive. Today, we are tearing into the precise clinical management protocols for when you get those transient papules like little bumps or mild edema after submucosal injections.
And we're pulling from a really wildly diverse stack of sources today.
Yeah, we've got clinical pathways from allergy immunotherapy, dental anesthesia, cutting-edge cosmetic dermatology, and, like we said, GI endoscopy.
Because we want to figure out exactly how these completely different fields troubleshoot the exact same tissue response.
Right, and to really understand how to treat the bumps and the swelling, we have to kind of understand why the tissue reacts this way in the first place, right?
Exactly. So if we look at the defining characteristic of the submucosal layer, which is just the connective tissue sitting right beneath the mucous membranes in your mouth, your lips, your entire GI tract, it's all about fluid dynamics.
Okay, what do you mean by that?
Well, it's really densely packed with vascular networks and capillary beds, but crucially, it has incredibly limited lymphatic drainage, especially compared to the deeper dermis or muscle tissue.
So when you introduce outside fluid, the tissue acts like a sponge that, has no way to wring itself out.
That's a great way to put it. It readily accepts the fluid, but the clearance is profoundly sluggish.
Mm.
And that localized fluid trapping is exactly what gastroenterologists are, well, hijacking during endoscopic mucosal resection, or EMR.
Right, because if they find a precancerous polyp on the surface of the colon, just slicing it off is super dangerous.
Yeah, there's a massive risk of cutting too deep and perforating the muscle layer underneath.
So they intentionally create this massive localized edema, like they guide a needle through the endoscope and inject a fluid bolus right into the submucosa.
Which physically lifts the polyp away from the muscle on this temporary fluid cushion.
Okay, let's unpack this for a second. It's like, I don't know, inflating an airbag under a rug to safely cut off a frayed piece on top without damaging the floor underneath.
Yes, that is a perfect analogy. And the mechanical properties of what you inject dictate how good that airbag is.
Right, because I was reading, they used to just use normal saline for this.
They did, but saline is isotonic. It lacks viscosity, so it just diffuses into the surrounding tissue and flattens out in a few minutes.
Meaning surgeons had to just constantly re-inject it to keep the polyp lifted.
Exactly. So the field pivoted to solutions that resist absorption, like high molecular weight hyaluronic acid.
Oh, because hyaluronic acid is so incredibly hydrophilic.
Right. It binds thousands of times its weight in water. It creates a really viscous, durable cushion that holds its shape.
Which is amazing. And some of the newer GI protocols even use these bioengineered thermosensitive polymers.
Oh yeah, like the Poloxamer 188 emulsion. Commercially, it's known as Eleview.
The fluid dynamics on that are just brilliant.
They really are. At room temperature, it's a liquid, so it flows easily through a long endoscopic catheter.
But then, the second it hits the submucosal space and warms up to body temperature like 37 degrees Celsius, it changes.
Yeah, the polymer chains undergo this rapid change and self-assemble into a rigid gel lattice.
It's literally a temperature-activated airbag. So in the GI tract, swelling is this elegant, life-saving tool.
It is. But what's fascinating here is that the very solutions used to save lives in GI surgeries are the exact same ones causing massive clinical headaches in cosmetic dermatology.
Right, because those identical hyaluronic acid formulations are the main ingredients in lip fillers.
Exactly. When you inject them into the submucosal layer of the lip to add volume, the tissue responds the exact same way. It traps the fluid.
And the hyaluronic acid binds the water to hold its shape. But in the lip, a dense localized cushion presenting as a firm cluster is, well, it's a dreaded complication.
Right. And knowing that this specific tissue stubbornly holds onto fluid completely changes the stakes when a patient has a reaction.
Whether it's a dental nerve block, sublingual allergy drops, or a cosmetic filler.
Yeah. The moment a nodule or acute swelling appears, the clinical protocol has to be super methodical.
So let's talk about that first line protocol. A patient is in the chair, the injection is done, and within minutes, a localized dime-sized papule pops up.
Okay, so what's your immediate instinct?
Honestly, I'd want to aggressively intervene, like maybe massage it to disperse the product or put a hot compress on it to increase blood flow.
And that instinct would actively worsen the patient's outcome.
Wait, really?
Oh, yeah.
Yeah.
Across all these disciplines, the universal first-line response is immediate de-escalation and precise observation.
Right. The guidelines from the Worcestershire Acute Hospitals NHS Trust about allergy drops are super strict on this.
Step one is always clinical reassurance and documenting the exact minute of onset.
To make sure it's just a benign localized reaction and not, the start of systemic anaphylaxis.
Exactly. You have to rule out an immunoglobulin-mediated response that would need epinephrine.
So, assuming breathing is fine, it's just a minor bump, the protocol is basically conservative management.
Very conservative.
Yeah.
The main treatments are localized cold compresses and H1 receptor antagonists.
Ice makes sense. It causes immediate localized vasoconstriction,
Right. By narrowing the capillary beds in the submucosa, you reduce the hydrostatic pressure that's forcing plasma out into the tissue.
which halts the progression of the swelling. And then at the same time, you use an oral antihistamine, like cetirizine.
And because the microtrauma of the needle puncture causes localized mast cells to release histamine.
And the cetirizine binds to the H1 receptors, physically blocking that histamine and shutting down the inflammation.
Without sedating the patient, which is key. But this phase also introduces a really critical constraint, especially in the peak wellness clinical pathways.
Ah, the do not touch rule.
Yes, they are uncompromising on this. Patients are strictly told to avoid rubbing, massaging, or playing with the injection site.
But wait, if I have a hard lump of fluid under my lip, my overwhelming human urge is to just push on it to smooth it out. Why is the restriction so absolute?
Because applying manual pressure disrupts a really fragile fluid dynamic.
How so?
When you massage it, you're applying shear force that overrides the product's viscosity. You risk physically shearing the medication or filler right out of the submucosal plane,
Oh, and driving it deeper into the muscle or pushing it up into the dermis?
which totally defeats the purpose of a targeted injection. You spread the drug to tissues where it shouldn't be.
Not to mention rubbing it causes secondary microtrauma.
Exactly. You're crushing delicate capillaries that are already damaged from the needle, which triggers more inflammation.
And you could displace the puncture seal, right? Like you could push skin bacteria down the needle tract and infect the area.
It's a huge risk. The only exception is in very specific aesthetic protocols where the provider does a highly calibrated, immediate molding to integrate the filler.
But if you do it wrong at home, you just fracture the polymer chains and create even worse clusters.
Right. The whole first-line protocol relies on biological restraint. Ice, antihistamines, and keeping your hands off it.
Okay, so let's fast forward 2 weeks. The patient followed the rules. The initial swelling is gone, but that little papule is still there.
This is where the clinical pathway hits a major fork in the road.
Because treating every persistent bump the same way leads to disasters.
Time is your primary diagnostic filter here. Normal post-procedural edema or minor hematomas will clear through the lymph system within about 14 days.
But if it outlasts that window, you have to figure out what kind of nodule it is.
Exactly. You have to pivot to a precise differential diagnosis based on tissue depth and immune response.
Like the protocols from Lias Med Clinic, they prioritize checking the mechanical depth of the material first.
Because a lot of times, a persistent bump isn't an immune reaction at all. It's just bad placement.
Right, the submucosal tissue in the lips has really thin skin over it. It lacks that thick outer layer, the stratum corneum.
So if a viscous product like hyaluronic acid is deposited too shallowly, it creates a distinct optical phenomenon.
The Tyndall effect.
Yes, due to Rayleigh scattering. The dense pool of filler scatters the incoming light and reflects the blue wavelengths back.
So the clinician sees this translucent bluish bump that feels soft.
Right. It needs mechanical correction, but it doesn't mean your cells are attacking it.
But what if the placement was perfect and it's still presenting as a hard, immovable lump weeks later?
Then you are looking at an aggressive immunological response. Your body sees the fluid or filler as a foreign invader.
And because that lymphatic drainage is so sluggish, it can't just flush it away.
So the immune system executes a containment protocol, encapsulation.
It's a crazy biological defense. Local macrophages swarm the site to try and eat the foreign material.
But when they realize the filler molecules are too big to break down, they change tactics and recruit fibroblasts.
Which act like microscopic construction workers, right? They just rapidly lay down these dense layers of collagen fibers entirely surrounding the bump.
Over weeks, they build a highly organized, impermeable fibrotic shell. They just wall it off.
leaving a hard nodule that won't go away on its own. But before a clinician even touches that shell, the protocol demands they rule out something way worse.
Yes, delayed onset soft tissue infections and biofilms.
If the bump is red, warm, or tender weeks later, it has to be treated as an infection.
Biofilms are the primary threat. Bacteria from the patient's own skin attached to the injected material.
And they don't just sit there. They engage in quorum sensing, talking to each other to secrete this thick, slimy matrix.
The extracellular polymeric substance, or EPS, it's like a biological bunker shielding them from immune cells and standard antibiotics.
Here's where it gets really interesting to me. If you have a biofilm, standard inflammatory treatments are actually super dangerous.
Oh, absolutely. If a clinician thinks a warm, red papule is just inflammation and injects steroids to bring the swelling down.
It's like throwing a blanket over a fire alarm.
Exactly. You're turning off the localized immune defense.
Which gives the shielded bacteria in that bunker free rein to multiply and expand the infection.
And the resulting tissue necrosis can be catastrophic.
So they have to be absolutely certain. They'll often start a multi-week course of aggressive antibiotics first.
Usually combining a macrolide with a fluoroquinolone to penetrate that EPS matrix.
To ensure the infection is completely dead before they ever introduce a steroid.
Right. You have to clear the infection protocol before managing inflammation.
Okay, so let's say infection is ruled out. The patient is healthy, but they still have this stubborn, encapsulated papule.
Now we move to advanced interventions. For hyaluronic acid, the chemical solution is hyaluronidase.
Which is an enzyme that naturally occurs in the body. It breaks the bonds between the sugar molecules in the filler.
It depolymerizes those long chains, breaking the cushion down into tiny fragments so the lymph system can finally clear it.
But the sources heavily caution against blind dissolving.
Yes, you can't just inject a bunch of hyaluronidase into the lip and hope it finds the bump.
Because the enzyme takes the path of least resistance.
Right. If you inject it blindly, it hits that tough collagen shell we talked about. And since hyaluronidase doesn't affect collagen, it just bounces off.
Meaning the enzyme then diffuses into the healthy surrounding tissue.
Or it starts dissolving the perfectly good filler the patient wants to keep, or even their own natural hyaluronic acid.
Leaving the patient with structural depressions, like actual hollowing in their lip, while that hard nodule sits right in the middle, completely untouched.
It's a cascading disaster, which is why the gold standard protocol relies on high-resolution ultrasound.
We're talking 15 to 20 megahertz transducers made specifically for superficial soft tissues.
It takes all the guesswork out. The clinician scans the submucosal plane and sees the tissue architecture in real time.
Looking for specific echogenic signatures, right? Like, a normal pool of filler looks dark and fluid-filled.
Anechoic. But a dense fibrotic capsule will show up as hyperechoic, a bright, thick white ring on the screen.
The ultrasound also maps out critical blood vessels, like the superior labial artery, so they don't hit them.
Armed with that map, the clinician guides a needle with millimeter precision, bypassing the shell to deposit the enzyme right into the core of the papule.
But what if the ultrasound shows the papule isn't just filler in a shell, but has turned into a solid fibrotic mass?
Right, because hyaluronidase can't dissolve solid tissue. In those rare cases, the protocol shifts to image-guided pinhole extraction.
That sounds intense.
It's highly specialized. Under continuous ultrasound, they make a microscopic stab incision, a pinhole.
And navigate microinstruments into the submucosal layer to physically extract the hardened nodule.
Leaving the healthy tissue around it completely undisturbed.
But wait, if ultrasound-guided extraction is the ultimate fix, why make the patient wait weeks through the ice packs and antihistamines? Why not just jump straight to the extraction?
Because jumping straight to extraction violates the whole principle of stepwise escalation. Pinhole extraction is still surgery.
It creates a new wound tract in a really vascular area.
Exactly. You're reintroducing the very micro trauma you were trying to avoid.
Risking secondary infection, scarring, and more inflammation.
And because that layer inherently struggles with drainage, any new surgical trauma guarantees prolonged swelling all over again.
So the wait-and-see protocol respects that the body is actually remarkably efficient. Most bumps will metabolize without a scalpel.
Escalation protocols just ensure clinicians only accept surgical risks when every biological avenue has failed.
Managing these reactions is really an exercise in methodical troubleshooting. It requires respecting the fluid dynamics of a tissue that swells fast but drains incredibly slowly.
It really demands acute patience.
Right. Starting with the timeline observation, then conservative vasoconstriction and antihistamines, and fiercely resisting the urge to poke at it.
And if it persists, pivoting to rule out dangerous biofilms before using targeted enzymes or ultrasound extraction.
It all comes back to the behavior of the submucosal layer, which teaches this profound lesson about clinical complications.
It really does. The exact same physiological response-trapping fluid to make a firm cushion is what prevents bowel perforations for a gastroenterologist, and it's the primary complication for a dermatologist.
The tissue isn't malfunctioning, it's just executing its biological programming perfectly.
Context is quite literally everything.
It totally shifts how you view localized reactions. It really makes you
Yeah.
wonder how many other symptoms, the things we rush to suppress or ice or call an adverse event, are actually highly evolved survival mechanisms that are just happening in a context we find inconvenient.
It's a fascinating perspective.
Something for you to mull over. Thank you for joining us on this deep dive. Keep questioning, keep exploring, and never stop wondering about the incredibly precise mechanics of the human body. We'll see you next time.